percutaneous intervention in large vessel systemic vasculitis. Systemic vasculitis, as per the classification being represented over here, includes various types, which includes large vessel, which is Takayasu aorta arteritis and giant cell arteritis. Medium vessel vasculitis includes polyarteritis nodosa and Kawasaki disease. And variable vessel vasculitis include Beckett's and Cogan syndrome. There are few others associated with the other systemic diseases, collagen vascular disease, and so on. Regarding the systemic vasculitis, the inflammatory condition affecting the arterial and the venous system. Its presentation is acute, and at the follow-up, they have a chronic disease. Acute stage is mainly associated with the systemic inflammatory symptoms and the signs, while the chronic disease associated with the multiple site stenosis or obstruction, and also the aneurysmal formation. The clinical presentation of systemic vasculitis depend on the organ system which is involved, which can be central nervous system, cardiac, peripheral vascular, peripheral arterial disease, renal and mesenteric arteries, pulmonary circulation, and also the deep vein thrombosis secondary to venous involvement. If you see the pathology, it's the inflammation and the mural thickening which is there, and later on, because of the negative remodeling, there is the stenosis and the obstruction, while the positive remodeling result into dilatation and pseudoaneurysm formation. This is also a milieu to have an accelerated atherosclerosis later on in the life because of the propensity for this lesion to have an atherosclerosis as well. Regarding the management, it includes the immunosuppression in the acute phase, which is nothing but the steroid and cytotoxic drugs like methotrexate and cyclophosphamide. For any emergency situation, there is a percutaneous or surgical intervention, but it's otherwise avoidable. It should be avoided to have to prevent the adverse outcome of any intervention in the acute stage. Those with a chronic or fibrotic disease, yes, you have to continue with the immunosuppressive therapy for the residue active disease or the relapse, and then they need the active intervention depending on the organ affected by the arterial supply. So let me go ahead for few of these systemic large vessel vasculitis. First one is the giant cell arteritis. It do affect the aorta, and its branches can present with the stenosis, occlusion, or the aneurysmal dilatation, and also the coronary arteritis. We from our center has published the data about the giant cell arteritis, and out of the 25 patients, it's the subclavian artery and the axillary, which is the common one, and descending thoracic and abdominal aorta is also found to be there, affected by the giant cell arteritis. The index case is a 59-year-old male with a painful swelling of the left iliac fossa, was found to have a bilateral common iliac aneurysm. On the left side, the aneurysm got ruptured with a large hematoma, 17 to 10 centimeter. Very painful, referred from the surgical department for possible endovascular intervention, and was treated with the endovascular stenting from in the left common to external iliac artery. Later on the evaluation was found to have a PET CT, which is suggestive of the active uptake at the local site. Further evaluation by the Department of Rheumatology lead to the diagnosis of extracranial giant cell arteritis, and which was treated accordingly. This particular patient had the asymptomatic 5-year of follow-up. Regarding the Kawasaki disease, you all know about it. This disease do affect the children and the adolescent, but then have sequelae as the coronary aneurysm and the stenosis later in the life. So we had a publication regarding, say, adult with the Kawasaki sequelae, and these are the two representative cases about the Kawasaki disease. The first one is 27-year-old male who presented with anterior MI, found to have a mid-LAD cutoff with the aneurysmal dilatation of the LCX and also the LAD. Another with the acute coronary syndrome had no prominent proximal LAD aneurysm. Regarding the Beckett's disease, it do involve both the venous and the arterial system. Arterial occlusion and aneurysm can be there, and the other vessel can also be involved in the Beckett's disease. It's our experience from our center, where out of 59 patients of the Beckett's disease, around 17% had vascular involvement, which include both pulmonary artery, and also the abdominal aorta is the commonest one. And around 60% of these patients had a deep vein thrombosis. So this particular lady, a known case of Beckett's disease, presented with a pain abdomen, found to an infrarenal abdominal aortic aneurysm with marked hematoma surrounding it. So it's basically the impending rupture, which was treated with a graft stent and had an asymptomatic 5-year follow-up. Another boy, a 6-year-old boy with a painful right arm swelling, was found to have a pseudoaneurysm of the brachial artery with a distal thrombosis, was taken up for the percutaneous intervention. The aneurysmal part was excluded by the coronary graft stent and is doing well at 6 months of clinical follow-up. Regarding the Takayasu aorta artery, you all know about the angiographic classification, and then there can be involvement of coronaries and the pulmonary arteries as well. From our center, we had 75 patients in which percutaneous intervention has been done, which include the coronary stenting. And the two commonly intervened vessels are the carotid and the renal artery. And we have also treated 7 patients of the bald aortic arch. Bald aortic arch is basically nothing but the occlusion of all the 3 aortic arch branches. So this particular case, published a long time back, left main ostial stenosis treated with a kissing balloon stenting. Another case, the young lady presented with a bilateral neck swelling, which is pulsatile and painless. Ultrasound did show the swelling movement of the blood column in both the carotids. CT scan confirmed the bilateral common carotid artery aneurysm. PET did show the active disease, for which a DSA was done, which could very well demonstrate the bilateral common carotid aneurysm. Left subclavian was intervened, had a balloon angioplasty, and was asked to go ahead for the surgical intervention. Regarding the bald aortic arch, the ideal treatment is the surgery. Surgery is going to be, say, transthoracic or extrathoracic. Transthoracic is going to require the sternotomy, and then you are going to put the graft from the aorta to affected, say, subclavian or common carotid artery. And this is what is required for this Takayasu aorta arteritis patient, because the extrathoracic or carotid to carotid bypass graft is not feasible in these patients, because all the 3 vessels are more or less diseased, though there may not be any stenosis. And this type of extensive surgery do have significant morbidity and mortality with a prolonged hospital stay. Sometimes the disease is so diffuse, you are supposed to go subcranial to have bypass grafting, and which do have its own complication. So this particular girl, a 16-year-old female, presented with the neurological symptoms, was having active disease, treated with the steroid, and this CT scan did show occlusion of all the 3 aortic arch vessels. Was treated for the right brachiocephalic and the left subclavian artery with the balloon expandable and self-expanding stent across them. It's basically self-expanding stent for both the brachiocephalic and also the subclavian artery. Day 7, she had a left subclavian aneurysm, which was treated with the graft stent. 3 months follow-up, doing well, no neurological symptoms, CT scan was fine. The ischemic retinopathy, which is again a problem with this patient or Takayasu aorta arteritis, has a marked improvement, and we could publish the data about the improvement in the ischemic retinopathy following intervention in one of the ophthalmology journal. At 4 years of follow-up, there is a problem. Both the subclavian artery stent got blocked, but then there is no neurological symptom because the patient had a patent common carotid stent. Another case, a 30-year-old male presented with recurrent syncope. He had a bypass graft to the common carotid, left common carotid, and the left brachial artery around 6 years back, which got occluded, say, after 1 year, and then had a TIA 1 year back. This is the situation. All the three aortic arch vessels are blocked, and both the bypass graft are also blocked, for which the right vertebral, right common carotid, and left subclavian to left vertebral intervention was done with a balloon expandable stent, and I had an asymptomatic 8 year of follow-up. Normally, when we do the angiography, a beaded appearance is very much suggestive of fibromuscular dysplasia. In this case, it's the beaded appearance of the left subclavian artery along with the left renal stenosis, which was intervened successfully, but the diagnosis was not clear. And it's the PET-CT, which is suggestive of, say, Takayasu aorta arteritis with the raised ESR and C-reactive protein, for which he was treated accordingly. We had a publication regarding the role of PET-CT to have an idea about the active disease in Takayasu aorta arteritis and found the sensitivity and specificity of 83% and 90% respectively. What happened in case you had done the intervention in the active disease? This particular boy had an intervention of, say, right brachiocephalic to vertebral artery, left subclavian, left vertebral, and left renal artery 1 year back. Again, become symptomatic, found to have an in-stent restenosis of all the 3 stents and occlusion of the left subclavian stent. IVAS was done at the baseline and following the balloon angioplasty and also the cutting balloon. There is a good result achieved across all the 3 territories. We do come across the aortic aneurysm infrequently in those with the Takayasu aorta arteritis. This particular case has both left subclavian, left carotid totally occluded. From last 8 years, he was on follow-up. Last 24 years, he was on the follow-up, presented with a pain. Pain chest radiating the back, was found to have 2 large secular aneurysm of more than 6 centimeters in the size and multiple juncta renal aneurysm as well, which was successfully treated with the graft stent. We have published a complex abdominal aorta and abdominal aorta arteries intervention. This is about the series of the 8 patient children less than 16 years of age, and one of the cases had aortic obstruction with the mesenteric ischemia, which was successfully treated with the self-expanding and balloon expandable stent, respectively. We do come across the in-stent restenosis in this patient with the arthritis. This particular lady had stenting on the left renal 8 years back, was found to have an in-stent restenosis with resistant hypertension because of the single functioning kidney, for which a renal autotransplantation was done. The left kidney was anastomosed with the left common iliac artery. Recently, we have done a few OCT across the Takayasu aorta arteritis cases. This is one of the publication of ours where the undilatable left renal stent, left renal stenosis was imaged, and you can very well appreciate the pan-arthritis with extensive fibrosis to the extent there is some calcification as well in the lower diagram D. And this particular run of the OCT did show the prominent vasa vasorum with the pan-arthritis, which is a characteristic and pathognomic feature of the Takayasu aorta arteritis. So in conclusion, the active disease in the systemic vasculitis should be controlled with the optimal medical treatment, which includes the steroid and the other immunosuppressive therapy. Endovascular treatment is feasible in selected patients. It's a safe, feasible, associated with the less of morbidity and shorter hospital stay. There are certain challenges of the endovascular treatment, those with the hard and calcified lesion, and at follow-up there is a concern about the in-stent restenosis, and those with the long diffuse lesion, there can be a problem. There are few unexplored newer modality of the management, which includes imaging and the drug-eluting balloon for the treatment, which has to be explored. I do acknowledge my team, which has helped me in the management of this patient, and also my patient who has the faith and has supported me for the active intervention of their disease in this particular subset. Thanks for the kind attention.